When we come to eczema, a lot of time we can't diagnose that particular rash has eczema, especially eczema have many phases of presentation according to chronicity and degree of degree of inflammations. In order to diagnose with confidence, we have to go back to the basic principles. Because if you're trying to diagnose eczema, the result is you become uncertain. You have tendency to say, this lesion looks like eczema, sounds like eczema, let's try this and that. If with confidence, your diagnosis should be, this is eczema until proven otherwise. In fact, this is acute, subacute, or chronic eczema with or without complication. That's a way we should phrase our diagnosis. We always say that even a durian dealer, they are able to differentiate one type of durian from another type by using major and minor criteria. Cannot be we are the so-called MBBS, MRCP holder, we're still guessing whether this is eczema, this is psoriasis, this is fungal, and this is etc., etc. So coming back here, the durian, how do we differentiate which one is Musang King? If you ask a durian dealer, they'll tell you that this is Musang King, but not by spot diagnosis. They're also based on minor and major criteria. So this is the shape of the Musang King, oval in shape. The cyst is flat. And according to them, the thorns are widely spaced, not so sharp, and not so painful if you sit on it. But of course, you need to sit a lot before you are certain how painful is painful. The next one is, one of the pathognomonic signs is the bottom of the durian. It's star-shaped. It's star-shaped here, but of course, later I asked some of my other friends who are good in differentiate durian and say actually it's not really that specific, but it's quite useful when you integrate all these minor and major criteria together. Same like another champion of durian, which is the black thorn. For unknown reason, the bottom of the durian are quite diagnostic. For black thorns, it's about 1.5 times more expensive than Musang King. They also have this black thorn at the bottom. So when it comes to eczema, how do we make a diagnosis with high degree of confidence? We have to go back to checklists. For my trainee in dermatology, there are 15 features they need to take before they say this is eczema until proven otherwise. But I think it's a bit too complicated for primary care, so I decided to narrow down to 1, 2, 3, 4, 5, 6. The first one is the presentation of eczema is very dynamic. They have no permanent or fixed image to represent this is eczema and this is not. They are very dynamic. The reason because according to acute, subacute, and chronic, the final image is due to the relative contribution of all these primary and secondary features. You look at this one, these are all the primary lesions, redness, papule, vesicle, and pustule. Once the vesicle and pustule you scratch, they will rupture. And once they rupture, they form this superficial erosion. Your body trying to put up a temporary shelter to shelter that particular area from external invasion. So the serosanguinous fluid from the plasma will cover up that deficient area. And of course, a more permanent way to replace the erosion is by improve or increase the epidermal cell turnover. As a result, you got more scales on top of it. If you put 5 days of steroid, stop 5 days, put 5 days and stop 5 days, as a result, you allow the inflammation, slow cooking your skin, and over time, they become lichenified. Lichenification means there are more prominent skin surface marking, they get thicker and get more firm, and also at the same time, they increase in pigmentation. So these are different primary and secondary lesions of the skin that represent different stages of eczema. So in short, eczema is due to a raw jux of primary and secondary lesion. It's not a single image. You can use it to say this is eczema and this is not eczema. So a true primary untouched virgin eczema is what? Is papular and vesicles. but most of the time we won't be able to get that. Only over certain area with thick skin, for example, palmar plantar, scratching itself does not rupture the blisters. You still can see this so-called pompholyx or this hydrotic eczema. But more often, when the patient walk into our clinic, they are in this stage. Superficial erosion, cluster erosion, or sometimes impetiginized means secondary bacterial infections. And if put 5 days of steroid, the lesions, the inflammation reduce. What you see is the ill-defined red scaly patches. And if you still not able to put into remission, they keep recur again and again, they end up with lichenification, as highlighted just now, with prominent skin surface marking, and also the induration, get indurated over time. So these are the 4 photos represent the 3 stages of eczema from acute, subacute to chronic. But of course, in real world, they don't really follow this compartment. They have a lot of overlaps. You can have many subacute with a few erosion over here is possible. It's a raw juxt of all these acute, subacute, and chronic images. And the second features of eczema is reversible. Exactly like asthma, you look at asthma definition, is potentially reversible. But if you allow the disease to go beyond certain point, the airway remodeling will occur. Same thing, skin remodeling will occur, means dermal fibrosis might take over the initial inflammation, and over time they become less reversible. Why the inflammation in eczema does not really cause long-term damage initially? Because the inflammation of eczema is mainly over the superficial epidermis, a little bit down in the upper dermis. So initially, if you manage to put the eczema into remission, the skin will go back to normal, although might have some pigmentary changes, but over time, if no recurrent eczema over the same area, the skin will back to normal. But among skin of color, the pigmentation might last much longer than the fair-skinned patients. And as highlighted, if you manage to identify early, they will resolve with just post-inflammatory hypo or hyperpigmentation. If otherwise, they will progress into chronic light stage. If you still not manage to stop promptly the progression, they'll become prurigo nodules. And at this stage, even though you might be able to arrest the inflammation and reverse it, some of the component might not be reversible. For example, one condition we call it post-inflammatory SOPAC leukoderma or vitiligo light. And this one indeed is quite difficult to reverse. Sometimes they have this for many years. The third features of eczema is overlaps. As highlighted just now, we are the one that compartmentalize eczema into acute, subacute, and chronic. But the skin, the eczema itself does not read our textbook. So in real life, you have a lot of overlaps. For example, in this child, with acute and subacute over the chest, and acute on chronic lichenified over the lower limbs here. You can see they are acute on chronic. And why we want to divide them acute, subacute, and chronic? Because when it comes to the duration of treatment, if you put only for 1 week steroid over here, there's no way you can reverse it. The more lichenified, the longer the duration that you need to apply the anti-inflammatory cream. Next, we have the fourth features. The fourth feature is surface changes. In contrast to another itchy condition, which is urticaria, in urticaria and eczema, both of them are very itchy. But in urticaria, the pathology is not in the epidermis, but in the dermis and angioedema in the subcutaneous fat. Whereas eczema, psoriasis, fungal infection, the inflammation mainly over the superficial part of the skin. Because the epidermis get inflamed, there are prominent surface changes. And that's one of the things we always use to divide different type of itchy condition, whether these are superficial epidermal inflammation or deep subcutaneous or dermal inflammations. So in eczema, the acute stage, you have prominent skin surface changes. You can see the lines here, and the lines get distorted, means the inflammation involves the superficial epidermis. Same apply over here. Another example is subacute also have prominent skin surface changes, and similarly in chronic lichenified, they also have prominent skin surface changes. As highlighted just now, in contrast to urticaria, hive, sopak, foam mok, you can see the sopak, foam, the kelopak garam, the foam mok, you can see the lines are well preserved. Means that the inflammation does not affect the epidermis. In contrast to eczema, have prominent skin surface changes. And this is a cross-sectional view of our skin. In fungal infection, psoriasis, eczema, the inflammation causes distortion of the skin lines, whereas for the urticaria, the inflammation is mainly in the dermis and angioedema, even deeper down, involving the subcutaneous fat. So the lesion over here, they will push up the overlying epidermis, hence the epidermis remain smooth in the setting of urticaria. Of course, sometimes life can be quite difficult when you have a patient with atopic eczema, at the same time with food-induced urticaria, cholinergic urticaria, you might have two different morphology on the same patients. And so this is another important differentiation between urticaria and eczema is urticaria, the individual lesion will resolve within 24 hours without leaving any stain over the affected area. Of course, the urticaria episodes can last for many years, but individual lesion should not last more than 24 hours. In contrast to eczema, in eczema, the surface not going to recover within 24 hours. If they recover also, they will leave some pigmentary changes over the affected area. So one of the ways to differentiate them is take a photo of the lesion, follow up 24 hours later of the same lesions. If they resolve without leaving any stain, there is a urticaria. If they're still there, or after some days later they resolve with pigmentary changes, then that is a true inflammation of eczema. Another features of eczema is they have ill-defined margin, especially atopic eczema. I do agree that certain eczema, like discoid eczema, irritant contact eczema to one single plaster, you might have well-defined margin. But in general, atopic eczema has an ill-defined margin. So both of them have prominent skin surface changes. On your left-hand side is psoriasis, on your right-hand side is eczema. Just based on the margin itself, you can divide them into two. Of course, for dermatologists, we have a condition called psoriasiform eczema, but I don't want to complicate the understanding about the differences between atopic eczema and psoriasis. So this is ill-defined. Ill-defined means I give you a pencil here. The way in your heart, don't say it out in front of a patient. You say, ayah, ayah, ayah. When you have more than 3 ayah, means you are not very certain that's ill-defined. Whereas this one is psoriasis, cannot be you say, ayah, 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 then you have to see a ophthalmologist if you still cannot outline the margin. So why is it important to understand this? Not just because of diagnosis, also for treatment. The main difference between psoriasis and eczema, psoriasis, the inflammation is like this, 10, 10, 10, 10, 9, poof, there's a cliff there. Means a very sharp demarcation between normal skin and the psoriasis skin. So the application will be quite simple. You just apply over the obvious area, maybe another 2 centimeters beyond the margin. But for eczema, it's very different. When you see there's an inflammation at the center is not like 10, scoring of 10, suddenly it disappears, but it's like 10, 9, 7, 4, 3, 2, 1, 0.5, 0.1. So it's have a sloping edge. When you apply medication over here, you really have to sit down, use a good camera. I use Huawei P50, P60 now. You use a night mode, you get the outline very nicely, and close eye feel for the margin of the lesion. If you just give them 2 tubes of medication, 1 tube of steroid, 1 tube of non-steroidal like tacrolimus, pimecrolimus, crisaborole, and 1 Avinor, and you pass to them and say, apply until okay. Is it okay? They say okay, but go back, it's not so okay. The reason because they don't know where to put, how long to put. You have to sit down, explain to them how to identify the margin of the eczema, and empower them how to apply it appropriately. So this sounds simple thing, but you really have to sit down and explain to them. And another important features is itchiness. If the patient walk in with a scaly lesions, and the mother say, my child never scratch, can sleep soundly at night, then you have to think twice. That might not be eczema. It could be pityriasis rosea, it could be lichenoides chronica, and etc. Yeah. So usually itch is one of the features. In fact, the earliest sign of eczema is itch. If you are a vigilant pediatrician or primary care doctor, you don't wait until the eczema become whippy, red, then only you start treating the patient. The first clue that the eczema is coming on a newborn, not a newborn, an infant, is they start to do something like this. They lie down there, they like to do that, and you put the face of the patient on the mother's shoulder, they will rub against it. That's the earliest moment that I am coming. We always say eczema is a disease that is a inflammation that come in this peribahasa called sikit-sikit, lama-lama jadi bukit, bukit-bukit menggunung dan gunung berapi. It's a process. It's not like yesterday the skin is 100% normal, tomorrow you develop atopic eczema and fulfill the criteria that set by Hanifkin and Rashka. It's a process. You can have a patient with subclinical eczema, clinical eczema, almost atopic eczema. They fulfill 2 out of 4 of the criteria. You still need to manage the patient has eczema, although you have not diagnosed the patient has atopic eczema. Yeah, so that's another important take-home message. So this is one of the features of eczema that always rub against. There's an earlier sign because kids cannot open the palms in the first few months of life. They cannot scratch in this way. They only do like this, they rub on him. So that's the way they act against the itch that they feel. So these are the top 3 most itchy conditions in children: atopic eczema, urticarial, scabies, and also insect bite reactions. Other conditions like psoriasis, pityriasis rosea, fungal, and ichthyosis, they do have itch, but usually it's not the most prominent presentation, especially in the early stage of the disease. So the degree of itch is very important, not just for diagnosis, but also important for management as well as the early detection of eczema flare. So if you, every time you prescribe a patient with medication, only when you see redness, whippiness, it's a bit too late. You always have to identify the earliest moment, mean a bit of dryness, a bit of itchiness, a bit of scaliness. That is the best time to intervene and not waiting for the eczema to get inflamed with redness. The early stage is like this, but because of the scratching activity and rubbing, they end up with this late stage of lichenification. And this does not stop over here. The eczema itch will spread from skin physically to psychosocial, because once the child cannot sleep at night, they make sure that the whole family also cannot sleep. The mother cannot sleep, the father cannot sleep. The psychosocial aspect of the patient will get disturbed. In fact, there's something called allergic march. It's not only referred to physical, but also refer to psychosocial, psychiatric march, and also financial march, because it's very expensive also to take care of the eczema babies. Another 2 more features, which is the background skin color, and this already highlighted earlier on. This is the fair skin eczema, different chronicity, and this is darker skin eczema. At this stage, it looks like there's no eczema. It's not true, because the pigmented epidermis block the red light from getting out from the skin and does not strike your retinas if you have very thickened, hyperpigmented lichenified eczema. In this case, your closed eye, you feel the lesion, they are rough. When you press on it, they are no longer soft, they are firm in nature. Means that there are inflammation hiding under the skin. So among the skin of color, obviously the first difference is they have less redness, and the second difference is they're more likely to have pigmentary problem. less redness. It's not difficult to understand why, because once you have a pigmented epidermis, it will block the red light from getting into your retinal swell. This is just an analogy that what is happening about the fair skin and this is dark skin. Sometimes I just joke that if I have two patients, one is Barack Obama, the other one is Donald Trump, I have to empower them differently. For Barack Obama, ask him not to look at the lesion. In fact, the best way to identify eczema, flare, among the dark skin is not using your muscle. You should close the eye, you feel for the scaliness, and then take a deep breath, meditate, and feel for the itchiness. That is the most reliable way. Because you don't have something called PFR for asthmatic patient, you have to use a readily available way to identify it, rather than you take certain parameter like serum TARC level to identify disease activity. So this is one of the major difference. As mentioned just now, another difference is the post-inflammatory hypo and hypopigmentations. They're more likely to develop clinically obvious hypo and hyperpigmentation. In fact, some of the patients, when they have hyperpigmentation, they come in asking for medication to remove the hyperpigmentation rather than asking medication to remove the inflammation. Especially when they have this hypopigmentation, it becomes very obvious among skin of color. Of course, the fair skin might not complain much when you have hypopigmentation, but the darker skin, they often complain of the not very homogeneous skin color over the affected area. And these are another common complaint. We have so-called dirty neck syndrome. And beside that highlighted earlier on, the follicular pattern. These patterns are more specific for darker skin patients, and in which the lesion started over the hair follicle, and over time, they coalesce to each other to form a follicular plaque lesions. And this is a patient that shown earlier on. This is a cross-sectional view to illustrate what I mentioned just now. Because the inflammation does not go horizontal, they go vertically down, and it becomes very difficult for the medication to penetrate. We have thickened scales and along the hair follicles. In fact, you look at the Hanifi and Rashka, one of the 23 minor criteria is perifollicular accentuation. Yeah. So this is one of the features that you need to pay attention. So before I move on to the second lecture, let's test what we have learned so far. Among these 9 photos, who has psoriasis and who has atopic eczema. So based on the margin itself, we already can identify which one is psoriasis and which one is eczema. So these are eczema with ill-defined margin, or atopic eczema more specifically, and the others are psoriasis with a well-defined margin. Of course, this is one of the features, but this is one of the useful features to differentiate one from another. And this is the case that I mentioned just now, when a patient with background eczema, lichenified, at the same time with urticaria. Some of them develop urticaria immediately after exercise. Some of them develop urticaria when they're exposed to hot shower or exposed to certain IG-mediated food allergy. And this one indeed is quite difficult to differentiate based on single photos. You have to observe, take a photo again with Huawei P50, take a photo 24 hours later, take a photo over the same area again. This urticaria, papules, and plaque should disappear without leaving any stain over the affected area. That's how we differentiate eczema from urticaria. Yeah, this is the first lectures. We have 30 minutes for Q&A, so anytime you all can stop me if you have questions. So if no question, I would like to move on to second lecture. Maybe I'm going to mix up the lectures, not according to the program. The main reason because I want to make sure that they are linked to each other. Yeah, is it okay? Oh, yeah, okay. Yeah. So, as highlighted just now, itch is one of the very important clinical sign or symptom for atopic eczema. First, for diagnosis. Secondly, to assess the degree of improvement. And these two are very important. In fact, we put each has a 6 vital signs in our dermatology ward or clinic. We always ask the patient to give us out of 0 to 10, how each is your yesterday 24 hours, the worst itch you experienced over the last 24 hours, especially during sleeping time. So 10 means katau gila, means cannot sleep at all, or once they sleep within hour or two, they wake up, scratch until bleeding. That's 10. And 0 is that despite the patient back from hot weathers like current weather in Malaysia, and at the same time, before sleep, also there's no itch at all, then consider 0. You can't assess the itch when the patient is holding a video game. That's not reliable because they get distracted by their video games. So that is the way to differentiate one from another. So itch related to atopic eczema is important for us to know beyond periodontal. A lot of time when we look at itch, the next thing in our mind is, give periodontal. Bear in mind that antihistamine or histamine-mediated itch is mainly for acute itch and not for chronic itch, especially atopic eczema. Let us take a look at the itch itself. If you look at Kamus Dewan, Kamus Dewan described itch as a sensation that induces a desire, ada niat dia untuk garu. It's a desire to scratch. That's according to the Kamus Dewan or any layman dictionary. But you look at the definition by medical textbook, this is not just a pleasant sensation, but it's something that can disturb not the child but the whole family, not just physical but psychosocial, mental, and financial aspect of the whole family. This is a very expensive sequence. Once the child have itch with eczema, some of the kids describe they are feeling like 200 female mosquito bites simultaneously on their skin. To scratch, the mama always say, ayah jangan garu lah, mengapa garu? Mata pesan, jangan garu, mengapa garu lagi? That kind of typical statement from the mother and from the kids. So this will induce a lot of negative emotion, not just among the father and the mother, but also the kids. The kids become miserable. They say, Mommy, according to Kamus Dewan, katau artinya garu, why you want to change the definition of Kamus Dewan and marah saya? So that make everyone get into a very negative vicious cycle. So you look at this definition and this description, this, as mentioned just now, is 200 female mosquito bite simultaneously. It's not only affect the physical, but also affect the psychosocial and mental aspect of the patients. So this is the poor sleep, loss of productivity, inflammation, and lichenifications, and secondary infections. You look at the quality of life impairment compared to others chronic diseases among children. Generalized eczema is just second to cerebral palsy in terms of disturbing or reduction in the quality of life or impairment of the quality of life of the patient and the family. It's not difficult to understand why. When you look at this video, I think most of you will agree with me, is how stressful is the mom. The child is sleeping, that the hands does not need any remote control. They know where to go and where to scratch. And in the morning, they are bleeding, their blood staining the blanket, and also over time, they become like infected and lichenified. In fact, we always ask my patient, you prefer itch or pain? Of course, most people without eczema will say, oh, definitely I prefer itch. Itch is a very pleasant sensation. But trust me, when the itch becomes very severe and prolonged, it's more painful than pain. Yeah. The reason because pain, you still can withdraw from it. You got pain, ouch. But itch is something that you self-torture yourself. The more you itch, the more you scratch until bleeding, then you feel, shock here until you get these sensations. Yeah. So the major difference is pain will withdraw. You got painful knee, you just rest your knee. You're not going to purposely go and hit your knee when you have pain. But itch is something that initially sounds pleasant, but you allow it to go beyond certain duration, they start to self-torture themselves. Yeah. This is another way to look at the difference between pain and itch. So pain, you quickly jump out from the boiling water, but you go to a itch sensation, you enjoy first, later you get killed inside this initially pleasant boiling water. There's a major difference between them. So this is a 3-year-old boy with atopic eczema since the age of 6 months old and become lichenified, disturb the whole family because cannot sleep at night. How do you manage such a complicated conditions when the itch become the hallmark and disturb the whole family? So these are a few options. Of course, you have a very busy clinic. We have a tendency to give them Piriton or sedating antihistamine. It's not effective. You add on a non-sedating, or the answer is combination approach. Obviously, the answer is option 4. You need to combine all and tailor to the background of the patients. This is not my recommendation. In fact, it's what is recommended by most of the international guidelines. You want to use sedating antihistamine, it's okay, but don't use it to manage chronic itch. Only during the acute eczema itch, for 7 to 14 days, you can consider using it for short term. Or you can use a non-sedating one when the patient has 2-in-1 or 3-in-1. Let's say a patient with atopic eczema, later in their life they develop rhinoconjunctivitis, you can use it, or they develop cholinergic urticaria, again, you can use the non-sedating antihistamine half an hour before they go out for exercise to reduce the risk of getting the urticaria during hot shower or during the exercise, which we call cholinergic urticaria. So this one of the patient will benefit from half an hour before any outdoor activity, because whenever the child walk out under hot weathers, within half an hour, he develop all this cholinergic redness, erythema, and sometimes become urticaria and feel itch, and they start to scratch. The underlying eczema get worsened because of these triggering episodes of urticaria and cholinergic erythema. In this case, I did advise the child to take non-sedating antihistamine half an hour before going out for any of this activity with a risk of getting cholinergic erythema. And this is a child after a few days of outdoor activity that will cause worsening of the eczema over the folded area. So some of you might think that I am a very busy clinic. I can't sit down and explain to mother about the combination approach, so complicated. I just get rid of them by giving them Piriton and also maybe the desloratadine to them. And the reason why is it so, because the itch, eczema-related itch, is not histamine-mediated alone. In fact, histamine only explains a little bit of the underlying immunopathogenesis of itch related to eczema. We do agree that especially acute itch, the histamine might act on H1. At the same time, they also act on another receptor at the itch nerve ending, which is H4. And we know that our conventional antihistamine mainly act on H1 and H2 that does not act on H4. They not antagonize the effect of H4. Besides histamine, there are many other mediators involved, including the interleukins, 2, 4, 13, especially IL-31 is a very potent cytokines that induce each atopic eczema patient. Others, including the proteases, leukotriene, substance P neuropeptide. That's the reason why some of the patients do respond to montelukast, but they don't have a very consistent response. Only some of them might respond to it. Others, including the ion channel, TRPV1 ion channel, TSLP, others like allogenesis, nerve growth factors increase the density of the nerve ending. So these are just some of the mediators involved. There are more than this. So unlikely by blocking the H1 up there, you can block the itch related to atopic eczema. So this is back in 1910. Indeed, if you are 114 years behind time, you are considered the authority if you use antihistamine, because back in 1910, by Day and Laidlaw have identified that histamine is the gold standard itch mediator. But this is in 2018 and now 2024. There are many other mediators. Now we can understand itch almost as good as understanding pain. Pain has developed much more earlier than itch in terms of the underlying mechanism. Now these are all the different mediators, not just the mediators, there also the receptor has been identified. So the take-home message is not for us to remember all this, it's just to take home one message is don't rely on Piriton to handle atopic eczema-related itch. It's very effective for urticaria-related itch by using sedating and non-sedating, but not so much for eczema-related itch. So if you still prefer that, then you are about 114 years behind time. So these are the three basic mechanisms that are responsible for itch related to atopic eczema. The first mechanism, which is increase in number of the chemical mediators that can directly stimulate the nerve ending, not via the histaminergic, but non-histaminergic as well. So this is a cross-sectional view of our skin. You have the itch nerve fiber here, and the mast cells, the TH cell, the keratinocytes, and also the ion channel that can directly depolarize the itch nerve ending without the help of histamine. The mast cells produce two key mediators. Of course, there are more than that. The two key mediators are the histamine, act on H1 and H4 over here, and the tryptase act on PAR2 receptors. And the TH cells will produce the IL-4, 5, 13, and 31, and they also have the receptor at the free nerve ending, and they can directly depolarize the itch nerve ending. The reason I want to make things a bit complicated, first I just want to show off that I do know a lot. Second one is to let you know that itch and related eczema is not really histamine mediated. Even the keratinocytes, upon chronic scratching, they also produce an alarmin called IL-25, IL-33, as well as TSLP. And even changes in the skin surface pH, skin surface temperature, they can directly depolarize the ion channel called TRPV1 and directly depolarize the itch nerve ending. So they don't need histamine at all in most of the examples, instances that induce the itch among eczema patients. When they get depolarized, the irritated itch nerve ending will send the signal along the unmyelinated C fibers at the same time across the spinal cord the brain and initiate the itch stretch cycle over here. And the more you stretch, the keratinocyte will produce more alarmin, more TSLP, and the cycle will go on and on until you become habitual. So this is the mechanism behind, and this is just one of the mechanisms. The second mechanism, we call it neuronal sensitization through hypernesis and allonesis. This is one of the elegant study by Professor Segura et al. From Japan, and he biopsied the normal skin, acute eczema skin, and chronic eczema and prurigo nodule, and stained for the free nerve ending of the itch nerve fibers, and found that the density of the free nerve ending over the prurigo nodularis area is about 3.5 times dense than the normal skin. Means over the skin of chronic eczema, the radar to sense for itchiness are a lot. Means just a mosquito flew across the skin, you already can sense by this radar. So just again, look at our cross-sectional view of our skin.
Close up one road and put all the stores in one place. Instead of putting both sides and then
to produce more TSLP and nerve growth factors. As a result, the free nerve ending is not only become more dense, they also become much
Take it
more
down and take it.
superficial. So they increase the density at the same
Not taking
time,
today, even
increase
leaving
the
that tomorrow only take it down.
superficiality of the free nerve
Another
ending. All the way,
breakfast
almost want to
reply.
come out from your skin
Another
already
will
and
be here
tie
by
to
10
the
o'clock.
surrounding. So just a little bit of changes in temperature, skin surface, getting a very harsh clothes in itself, a bit of friction can induce itch over the affected area. This is what we call it the hypernesis. And this again to demonstrate the green stain show the level of the free nerve ending. In normal skin, it's up to dermal epidermal junction. This is epidermis, this is dermis. But in the lichenified skin, they go all the way up almost to the stratum corneum area. Means they become very sensitive to changes, surrounding changes. Next is called allochnesis. What is allochnesis? Allochnesis means a sensation that normally does not cause itch, induce itch over the eczematous and the surrounding area. For example, let's say I'm standing under an aircon, the wind blow on my face. Normal skin we feel, oh, very pleasant. But over the eczematous skin, this wind blow will induce itch and the child will start scratching. Even though you have a bit of long hair and the hair move over the eczematous area, the child will perceive an itch and start scratching the affected area. That's the definition of allochnesis and hypernesis. And lastly, once you allow the disease to go beyond certain chronicity, the katau kulit jadi katau otak means they become habitual. And most people agree, I believe most of you agree with me that this eczema over here, 95% induced by herself. Because the area that cannot reach conveniently by her fingers, there's no eczema over this area. One day I just joked with this girl, and go and practice yoga lah, then you can scratch your whole back and redecorate your back with different pattern of eczema. Just to highlight the habitual itch also contribute to the itch. So if you sit for an exam today, which are the anti-itch measures? If you go for 11, oh my God, so many, you won't score any marks, but of course, you also won't lose any mark. So the answer is all of above. Including all this, you have to tailor according to the background of the patient and the severity of the itch. Let's go through them one by one. First is by behavioral modification. We always like to, if the child scratch, we like to say, ayah, jangan garu lah. Sudah pesan jangan garu, mengapa garu lagi? 不要抓啦，因为抓了又流血了, or something like that. Yeah, but it does not work. Just like the smoker, you say, I don't smoke lah, they go to the back side of go to the back of the hotel and start smoking in the back side, at the back of the hotel. So we need to train them. Wherever you have itch, you can put the cream there, you tap, or you just rub, or you massage the area. Yeah, that is one of the way to break that negative emotion and the vicious cycle. Others including wet wrap. Wet wrap, you can tailor it according to the background of the patient. If the house is very crowded, very hot, sometimes the wet wrap may exacerbate the eczema. So you need to make sure that the home environment can support the wet wrap. And you no need to apply for whole body. You can apply over certain area that have a more lichenified and severe itch. The next one will be the environment. A lot of kids with eczema, especially the folded area eczema, they don't like hot weather. The minute they play outdoor, they get sweating, they start scratching, they like to stay indoor. But once they stay indoor in an air-conditioned room like this, initially it's very pleasant. After 2 hours, they start to have dryness, and the dryness also will induce itchiness. So all depends on the extreme environment. You have to get it right according to the age of the patient and the activity of the patients. Next is you can use a combination. We can use steroid, non-steroidal like crisaborole, tacrolimus, pimecrolimus, and now we have another one called JAK inhibitors, not in Malaysia yet. Others including the moisturizer with anti-itch property, like Avinol, they have avinantromide, they have a direct anti-itch property. Others including the normal moisturizer. So this is the avinantromide that present in the Aveeno, they induce not really full remission, but improve the itch over 14 days. When they stop using the Aveeno, the itch come back again. But at the end of the day, bear in mind that anti-itch measure don't rely on one single cream. If this cream can offer 30%, you get another measure to get another 20%, then you add it together. And don't rely on one, and if that does not work, don't throw it away. It still works when you use a combination approach. Next, those very severe, then you can refer to your dermatologist or pediatric dermatologist in your hospital or near your area, because now we have very effective anti-itch medication. Unfortunately, at the same time, it's very expensive. Some of them, you can see the effect within 3 days, almost as good or even better than oral prednisolone. Yeah. So unfortunately, although they don't have skin atrophogenic effect, but they have wallet atrophogenic effect because it's very expensive. Yeah. So they are called biologics or JAK inhibitors. In fact, they are already approved for kids 6 months and above in Malaysia. You can see this is one of the biologics called Tupilumab. It's the IL-4, IL-13 inhibitors. The reduction of the itch is very rapid. In the first 1 to 2 weeks, you already can get at least 10 to 20% reductions. And if you use it up to 16 weeks, they reduce to about 50% in terms of the itch scoring. And this is one of my patients, very severe lichenified eczema. You can see the skin, because they believe in something suggested by TikTok. TikTok say atopic eczema, most of patients will recover by 5 to 7 years old. So the mother just wait until 5 to 7 years old, and this is what is the result when you allow the eczema become chronic lichenified. And see how severe is the eczema. But this is after 16 weeks of this treatment, and this is after 16 weeks, after 32 weeks, and after 52 weeks. Of course, this is not that easy. Just come in and jab the patient. It does not work in that way. You still need to empower them how to take care of eczema. And this one, from 0 month to 52 weeks, it costs us about 30,000 to achieve this result. Yeah. And of course, others medication like the ruxolitinib topical, but it's not in Malaysia yet, these two. And the systemic one, we have upadacitinib in Malaysia, and baricitinib we use pretty much for the COVID patients last time, and now we do have a few patients on baricitinib because of the underlying eczema. And this is one of the patients on oral upadacitinib. Again, it's very severe, and this is after about 2 months later. And again, all this medication costs you 2,500 to 3,000 per month in order to induce the remission. You might need to put the patient for 6 months to 12 months. It's not cure, but it's really helpful in improving the quality of life of patients over months and not over days. There are many other future medications, including one of them is H4 receptor, but it's not available yet in Malaysia. And IL-31 is nemolizumab, also very effective in reducing itch. So this is about my second lecture. Is there any question? If no question, we move on to the third lecture. Hey, there's a question. Yeah. Sorry.
Now, it seems that from your list just now, the focus of treatment is against itchiness rather than to treat the eczema.
I mean, to against the itch.
Yeah,
Itch is just one of the components, but this component always disturbs the patient the most. And not only disturb the patient the most, but itch also is a very reliable early sign of eczema flare. So we have to pay a lot of attention about this itch. But there's study using another medication called nemolizumab, purely anti-itch, but anti-itch itself is not able to stop the eczema progression. But is very helpful in terms of quality of life impairment, also to prevent the secondary lichenifications.
So is there any effective treatment to stop the eczema rather than just to stop the issue?
Beg your pardon?
Is there a really effective treatment to stop the eczema rather
Yeah,
than just to stop
yeah.
the issue?
Of course, all four components, the itch, dryness, inflammation, and infection, all these four, you have to act on them simultaneously. Itch is just one of the four key problem or key sign and symptom for atopic eczema. Of course, you cannot just handle the itch without handling the inflammation and the dryness. All of these four need to be handled simultaneously. I don't know why it's a quick PowerPoint. Yeah. Yeah, okay. Then we move on to, you want to, oh yeah. 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 1.5, huh? Yeah. Okay. Yeah. Yeah. Let's say you already found the right potency of steroid for that particular area. Generally, the rules is we call it the fingertips unit. Let's say this is the medications. You put from here to here. This is considered one fingertips. One fingertips is enough for 2 palm size. So you can use it as a rough guide, how much you need to put on the patient. Let's say the patient only have a lesion over here. Let's say over this area, means 1 palm size. You give half of it over here, another half over here. And the way we apply, we need to apply beyond the margin. Because eczema, the margin is beyond what your naked eye can identify. Unlike psoriasis, you can identify the margin very well with your naked eye, but not so much of eczema. So this one will be this area. And same apply to moisturizer. When you apply moisturizer, first time when you empower the mother, make sure they use it adequately. Some mother buy 50 gram of moisturizer. After 1 month coming back to see you, you ask the mother, have you applied moisturizer adequately? Yeah. But you still need to get another tube. No, still half tube in my home. So it's impossible if you use it adequately and you still have half tube. To apply a human like me, from head to toe is about 20 gram per application. You buy a 50 gram moisturizer, after 1 month, they still have half tube. That means the mother have not used it properly. Yeah. So next question is about the duration. Unfortunately, I don't have the lectures on steroid, but just briefly, there's no fixed duration. Whoever fixed the duration means you just want to get rid of a patient. If you really want to use it properly, you have to use until the lesion becomes smooth, become flat, no more itchiness, and no more redness for fair skin patient. But of course, I can't give you a precise duration. Some patient over the face, you just need 7 days. Some chronic lichenified lesion over the lower, you might need 3 to 4 months. Whoever want to get so-called the guideline recommendation, it's very easy to say apply 2 weeks and stop. But you're not helping your patient. After 2 weeks, definitely the inflammation improves. The minute you stop, you are not continuing with an anti-inflammatory agent like the non-steroidal or moisturizer like Aveeno. The thing is that the eczema will come back again, inevitably. It definitely will come back again over the hotspot area. So you need to empower the patient how long to apply. You cannot fix the duration. But once you break the rules, that what is recommended by guideline, that needs shared decision, firstly, they need proper documentation. Now with the current smartphone, you can take very nice photos. Not like last time, Nokia 3310, you take something more blurred than your naked eye. You can't identify the telangiectasia. You can't identify the skin line. Then your photo is not good enough for monitoring. So let's say I apply on one patient over the face. I will take a photo and ask the mother to take the photo together with me over that affected area. Since we start on steroid and you are worried about the skin thinning and telangiectasia, let's monitor it together. So you take a photo, then ask the mother to keep the photo. 4 weeks later, you come back, you compare and show the mother there's no skin thinning, there's no telangiectasia. In fact, in Hospital Kuala Lumpur, we just done a study using mometasone for 6 weeks. We use ultrasound to measure the skin thickness. We use dermoscope to look for telangiectasia. Over the side, outside the face, actually there's no obvious skin thinning and telangiectasia. But unfortunately, it's very difficult to empower the parents because they always get the negative impression about steroid from TikTok, from Google, and from their traditional doctors, that steroid is always lousy and cause problem among the patient with eczema. Yeah.
Thank you, Dr. Leong.
Yes.
The second question is about the age of onset of eczema.
Yeah.
So if a patient never had any history of eczema or allergy in the past, so can he develop eczema at adult onset, like 40 or 50 years old, as a first presentation? So regarding the age of onset, assuming there is no any exogenous cause, no any irritant or allergy induced, no any atopy history, is it likely to develop at adult onset at that age?
Yes.
If let's say it's not due to the eczema, a patient presented with generalized eczematous patches, usually in primary care, we just give some oral or injectable steroid. So what are the clues or any secondary alarm features that make you think that there could be some endogenous cause which you need to do some blood tests or allergy testing in patient with first presentation of eczema at older age? Thank you.
Yeah, okay. Obviously, there's a subtype of eczema, we call it late onset atopic eczema. In fact, in Western country, they've documented up to 25 to 30% of atopic eczema. Initially, they go into remission. This subset, after certain years, they might flare up again. And in fact, another group is never have atopic eczema before. They develop eczema after 30 or 40 years old. So this subtype is definitely there. But coming back to your question about what are the differential diagnosis of each among the older patients. Yeah. Let's say you have itch, very severe itch, but there's no obvious skin rash. There's a big topic there. You have to look hard for any underlying lymphoma. You have to look for any hypothyroidism and mycosis fungoides, etc. Yeah. But let's say they have obvious eczema that you attended my first lecture just now. They fulfill the eczema criteria, and they have eczema. First, there only itchiness accompany the eczema. It's not you have itch because of scratching that induce eczema. Let's say there's a second group, means eczema with itch. This subset you can manage exactly like how you manage atopic eczema in children. Yeah, it's definitely there's a subset that have a late onset atopic eczema, especially when you suddenly move to a new environment. Initially, maybe your skin is just dry. You don't like tropical country, you migrate to New Zealand, for example, and you go to New Zealand, you still adopt the same lifestyle in tropical country. Every time you just bathe 3 to 4 times a day using harsh cleanser. A relatively dry skin will progress to drier skin, and finally they may end up with eczema also. So eczema is a contribution by both genetic and environmental factors. Certain patients, maybe 10% from genetic, 90% by environmental factors. And another subset, maybe 80% from genetic. Means the minute the child delivered, within 4 weeks to 6 weeks, they already develop atopic eczema. Means that environmental factors are not that important. It's a genetic that predispose someone to atopic eczema, no matter what environment you are in. Yeah. One more question before we move on to. Yes.
If you are using,
Yes.
if you are using if you are using 2 creams and above, do you mix them together or how do you use it?
You mean you're using two creams?
Yeah, one
two
cream,
medication?
two medications
Yeah,
or more.
yeah,
Do you mix them all together
yeah.
or how do you use it?
And the answer is really based on whether you want a practical answer or guideline-based answer. If you want to follow the guideline, they always say you interval by 15 to 30 minutes between each applications of whatever cream that you decided to apply. Let's say you want to put moisturizer first, then 15 to 30 minutes you put your anti-inflammatory cream, be it tacrolimus, pimecrolimus, or steroid, or the other way around. Yeah. So whether is it evidence-based, to be honest, there's no strong evidence to support that. That's why practically I don't really insist the catechol to follow what is recommended by the guideline. In fact, I ask them to apply immediately one after another. Now the question is the sequence. Some guidelines say you use moisturizer first, then only you put the steroid or non-steroidal. Again, the practical answer to this is how confident are the parents about the site that they need to apply the steroid or tacrolimus. If let's say you have a fair skin patient, you see the redness there, you apply the moisturizer, you won't be able to feel for the scaliness and the border of the active margin. So if the mother close their eyes, already know where are the hot spot, where are the margin, it's okay. You can apply moisturizer first, then followed by steroid. But the mother is not very confident about the margin of the eczema. I personally prefer steroid first, because to identify the margin is not only looking for redness, especially skin of color. You have to feel for the margin. In that case, I prefer using the medicated cream first, then followed by moisturizer. Yeah.
Thank you.
So, want to stop first, or we continue for another lecture? Maybe you continue first.